Good afternoon, everybody. Welcome back to Grand Rounds. Today we have Kirsten Trudeau talking about respiratory illness and when should antibiotics be prescribed. Kirsten?
Thank you. Let me share my screen. All right, can everyone see my screen?
Yes.
All right, so thank you all for joining us for Grand Rounds today. I'm Kirsten Trudeau. I'm one of the nurse practitioners here at Norton Infectious Diseases Institute. So today we're going to cover a topic that aligns with our November monthly newsletter. This topic is timely given that we're going into respiratory season. That being said, today we'll discuss respiratory illnesses and when we should, or more often when we shouldn't, be prescribing antibiotics. So as cases of respiratory illnesses go up, you start seeing more patients flow into primary care offices, urgent cares, ER. And then the question as the provider becomes, do they need antibiotics or supportive care? And interestingly enough, some studies have shown that antibiotics are inappropriate. Many antibiotics are inappropriately prescribed for respiratory illnesses, and we'll look at some of that data later. But additionally, the patient's perception also plays a role in their expectations during the visit in regards to antibiotic prescribing. So hopefully by the end of this presentation, you'll have more confidence in treating respiratory illnesses, as well as providing education to your patients. So let's get started. Funding for this presentation was provided by the Kentucky Department for Public Health. Content includes discussion of unlabeled use of products. Presenter has no financial interests or other relationships with the manufacturers of products, and no commercial support was provided for this educational activity. So by the end of this presentation, you should be able to define the types of respiratory illnesses, analyze the role of diagnostic stewardship in respiratory illness management, apply guidelines, and demonstrate the ability to identify when antibiotics are appropriate for respiratory illness, and summarize the impact of antibiotic resistance on public health, and formulate a plan of recommendations for a case study scenario. So respiratory illnesses present in a variety of ways. So here we have a comprehensive list compiled from the CDC and the American Academy of Family Physicians, or the AAFP. So providers see most of these on a regular basis, and while some illnesses like pertussis and epiglottitis are less frequently seen, it is important to note, especially when it comes to treatment. So on this list, we've got colds, runny nose, sore throat. So this would be like your viral pharyngitis that would exclude strep throat, COVID-19, influenza, bronchitis or a chest cold, middle ear infections, sinus infections, pertussis, epiglottitis, laryngitis, pneumonia, and strep throat due to group A strep. So take a look at this list. How many times have you treated one of these, seen someone treated, or even been treated yourself? Think about it. Did you receive an antibiotic? If you're comfortable and would like to drop in the chat if you've received an antibiotic for any of these illnesses and for which one, it'd be interesting to see that. So if so, please drop in the chat. So we have defined what respiratory illnesses are. So let's take a look at some of the data. So when did we start noticing an uptick? So the Lancet Infectious Diseases published an article showing that from 2000 to 2010, there was a 36% increase in antibiotic use. So we started to notice this, started to give this a bit more attention in years since. So looking at some more studies, JAMA published a study in 2018 that had 5 United States sites. It had 15,000 patients with acute respiratory illness. 41% of those were prescribed an antibiotic, and of those 41% that had a diagnosis that did not support the use of an antibiotic. And this isn't just a problem in the United States. As far as Australia, from a 2016 ARA report, 30% of the participants in the study were prescribed an antibiotic in a year's time, and greater than 50% of them had ARI symptoms and were prescribed an antibiotic that was not indicated. And then just a little bit more outside of the United States to show that this is a global problem. The Annals of Internal Medicine in 2012 published a study out of Ontario, Canada, With 185 patients seen for non-bacterial acute respiratory infections, 46% of those people were prescribed an antibiotic that was not warranted. So you can see that the data shows that about 40% of the time, people are prescribed antibiotics for respiratory illnesses that were not actually indicated. So antibiotic overuse and misuse leads to resistance. And so how does antibiotic resistance happen? There are a lot of germs and few are resistant to antibiotics. And then when antibiotics kill the bacteria causing the illness, they also kill good bacteria that's protecting our body from infection. Then those antibiotic resistant bacteria grow and take over, and then some bacteria give their resistance to other bacteria and just causes more problems. So some of the mechanisms of resistance include reducing intracellular antibiotic concentrations, antibiotic inactivation by changing the enzymes or chemical degrading, target site alteration by mutating or eliminating the target site, antibiotic modification, or target site protection. So the role of the antibiotic. This is a really simple statement from Stat Pearls, but I do think it's something worth mentioning as we see so many antibiotics prescribed for people suffering from viral respiratory illnesses. So Stat Pearls states that antibiotics are compounds that target bacteria and thus are intended to treat and prevent bacterial infections. So we need to remember this when we discuss the guidelines for treating respiratory illnesses. So antibiotics work to destroy the bacterial cell in one of two ways. They prevent cell reproduction, or they modify a process or function inside of the cell. Antibiotics are either bactericidal or bacteriostatic. So bactericidal kills the bacteria. Bacteriostatic prevents growth of bacteria. So when we have targeted therapy with an accurate diagnosis, that is how we use antibiotics appropriately. So some good examples of this would be pertussis, epiglottitis, strep throat. We identify a diagnosis and choose a target therapy as such. So how do we get those accurate diagnoses without over or under testing? We need to be good stewards of our diagnostic tools. So diagnostic stewardship. We've all heard of antibiotic stewardship, but diagnostic stewardship is equally important. The main objective of microbiological diagnostic stewardship is patient management guided by timely microbiological data to deliver safer and more effective and efficient patient care, and to have accurate and representative antimicrobial resistance surveillance data to inform treatment guidelines and antimicrobial resistant control strategies. So when we underutilize or use tests incorrectly for microbiologic and diagnostic testing, this can have a negative impact or negative effect on management, less optimal or poor outcomes for the patient, a lack of representative surveillance data for empiric treatment recommendations, and antimicrobial resistant control strategies. So let's look at this diagram and we can kind of talk through an example. So we've all seen this. A patient comes into the ER with mild URI symptoms for 3 days. Their clinical presentation checks all the boxes for a viral URI, but you're a new provider and you really want to make sure you aren't missing anything. So you order the whole panel of tests, which includes a full set of labs, a blood culture, and a respiratory pathogen panel. The labs are fairly unremarkable. However, the blood culture comes back positive for a coag-negative staph. The RPP is positive for influenza A. So now you have a patient with a positive blood culture that is likely a contaminant, but you collect another culture and admit for empiric antibiotics until you're sure. This alerts the labs of an antimicrobial resistance possibility, and in reality, the patient has the flu and could have been sent home with supportive care. So a blood culture was not necessary in this situation. However, testing for viral illness was a great choice to confirm that antibiotics were not warranted at this time. So it should be noted that an RPP or respiratory pathogen panel is pretty expensive compared to a general like COVID flu RSV test. So perhaps we could have started with a COVID flu RSV test and then moved on from there. But the bottom line is that sometimes more testing is not better. It's the right testing that is important. So as we just discussed, there are some options for point of care testing. These allow us to target a source of infection to determine if the diagnosis is viral or bacterial. So this will not always provide us with the answer, but we must be a good investigator as we diagnose and treat our patients. So point of care testing, some options that are available are influenza A and B, COVID-19, RSV testing, and group A strep for strep throat. So again, some considerations for the respiratory pathogen panels. As previously mentioned, these tests can be pricey. So the CMS reimbursement is $417, but what if the patient has to pay out of pocket for this test? That can be really difficult, so that should definitely be something that we consider. Chest x-rays are critical to the diagnosis of pneumonia. However, that chest x-ray is not going to tell us if the source is viral or bacterial. So we'll discuss how that impacts our treatment here shortly. So let's take a look at those respiratory pathogen panels. This consists of a panel of 24 pathogens, both viral and bacterial. So let's compare the cost of an RPP versus the flu COVID RSV test. The RPP ranges that I've seen in price have ranged, I've seen ranging anywhere from $140 to $614. And while the cost of the COVID flu RSV is roughly $40. So the American Journal of Clinical Pathology published a study in 2019. The article was choosing the right test for influenza versus respiratory viral panel with faster turnaround times and cost savings. So there was a medical center in New York. They looked at 69 specimens from the beginning of October in 2018 to the end of January in 2019. So roughly, 3-4 months. So they looked at all of the respiratory viral panels. The total negative for those were 74%. And then the positive, those that were positive for flu and RSV were also positive on an in-house or point of care testing for flu or RSV. So for that particular facility, the clinicians recommended to start ordering the in-house version as first-line therapy, first-line treatment. So the total savings over a 1-month period was actually $80,000. And the in-house test was considered to be highly sensitive and specific, relatively low cost, and should be considered as a first-line test. So this table lays out the recommendations for antibiotic therapy for respiratory illnesses. I tried to build this table using 3 different sources, the CDC, the AAFP, and UpToDate, just so that we can see that they agree and most all of their recommendations align. So you'll notice that for colds, viral pharyngitis, COVID-19, and influenza, all 3 organizations unanimously agree that no antibiotics should be prescribed. For bronchitis, UpToDate states that only in rare instances should antibiotics be given to improve outcomes. This is reserved for cases when a specific pathogen like pertussis is suspected, so like a secondary illness, or confirmed in high-risk patients if treatment would limit the spread of a contagious disease. And then the AAFP noted the Cochrane review, which suggests no benefit to using antibiotics for acute bronchitis in otherwise healthy individuals. So I think that they put the rarely comment in there to consider for adults or individuals that may have some other comorbidities. So middle ear infections, we treat with antibiotics in children with severe illness or bilateral infections, but otherwise they recommend watchful waiting, and that's consistent across the board with all 3 groups. Sinusitis is a maybe, and this is also consistent across the 3 groups. So we do watchful waiting for most. Antibiotics for severe or complicated bacterial sinusitis. So what does that mean and what does that look like? So we would have one of these criteria, onset of severe symptoms. So that would be a fever greater than 101.2, purulent nasal discharge or facial pain that lasts 3 to 4 days at the beginning of the illness, persistent symptoms for 10 or more days with no improvement, or if there's worsening symptoms for 3 to 4 days. So that is consistent across all 3 groups. So you'll notice that for pertussis, all 3 groups agree, yes, treat with antibiotics. Epiglottitis, absolutely treat with antibiotics. I will say I did put a note by the CDC because they specifically for epiglottitis only had recommendations for epiglottitis caused by Hib. But there are obviously other causes of epiglottitis, but I just wanted to make note that the CDC only gave recommendations on Hib that I could find. But for laryngitis, there is no need for antibiotics. Up-to-date states that antibiotics are not indicated unless a clear coexisting bacterial infection exists. For pneumonia, up-to-date recommends empiric antibiotics are recommended. And so this is, if we think back to our slide about the x-ray, so the x-ray is not going to tell us if the patient has viral or bacterial pneumonia. So that is why it's important to start those empiric antibiotics, and you can de-escalate as appropriate. So then, of course, with strep throat, all three groups agree we treat with antibiotics. So let me sum this up for you all in a little bit easier to read slide. So automatic yes treat with antibiotics are going to be your pertussis, epiglottitis, community-acquired pneumonia, and strep throat from group A strep. So our maybes are the sinusitis or middle ear infection, and our rarelies are bronchitis. So let's say now that you have a patient with a viral respiratory infection that does not need antibiotics. You send them home with supportive or symptomatic treatment, but what does that really mean? And does your patient actually know what that means? So these recommendations are from Up-to-Date. Some alternatives to antibiotics for supportive or symptomatic treatment include analgesics. So this would be your Tylenol, Motrin, unless contraindicated, antihistamine decongestant combinations, your intranasal or inhaled chromium sodium, intranasal ipratropium bromide. And in addition to that, there are some other therapies that have minimal or uncertain benefits. So your dextromethorphan for acute cough, decongestants for nasal congestion, saline nose spray, expectorants might thin out the secretion. Honey has been shown to be effective for cough. Herbal products that are recommended for general URI symptoms really need more studies to be conclusive. There's just not a lot out there. And then additionally, we heard a lot about zinc at the height of COVID. However, zinc is actually not recommended due to those potential adverse effects. And then patient education is essential to ensuring that your patients have the knowledge to care for themselves and empower them with their knowledge that they actually can get better without an antibiotic. So studies have shown if a patient expects an antibiotic, a provider is actually more likely to prescribe one. These are some discussion points you can include when you're educating your patients on respiratory illness. So hand hygiene, face masks, cough etiquette, staying home when they're sick, getting vaccinated, educating on the difference between virus versus bacteria, and then your antibiotic risks. So additionally, the CDC has some great infographics on their website that you can post around your facilities, your exam rooms, waiting rooms, and this can help positively reinforce the education you're providing on antibiotics and respiratory illness. So I'll show you a few of those examples. So you'll notice that this is similar to the table that I showed you earlier, but this one is geared towards patients to help them understand what type of pathogen made them sick. It easily shows that a virus-only cause does not need antibiotics. A bacterial cause would require antibiotics, and those that could be caused by either have the potential to need antibiotics, with the exception of bronchitis rarely, as we discussed earlier. So then we have a few more resources. So this is just, do you need antibiotics? So for common respiratory infections like cold, bronchitis, flu, COVID-19, the antibiotics don't actually work. And then for, do I really need antibiotics? So educating our patients on when to say yes to antibiotics. We say yes to antibiotics for bacteria. We say no to antibiotics for viruses. And that makes it really simple for them to read, posted around your facility. And then what if your patient's worried about, can I get better without antibiotics? And you can, show them this infographic, you can post it around and just explain to them that respiratory viruses usually go away in a week or two without treatment. They just need to make sure they're doing good hand hygiene, covering their, mouth when they cough, stay home when they're sick, and then recommend getting vaccinated. And then this is kind of a heavier infographic, but it is nice for antibiotic resistance. Just to remember that, 2.8 million people are annually infected with an antibiotic-resistant infection, and 35,000 of them will die as a result. So I think that's really important to help point out to your patients when you're trying to educate on why they don't need an antibiotic. And additionally, there's also downfalls to the use of antibiotics. So 1 in 5 hospitalized and emergency room patients will have an adverse antibiotic reaction. And there's also that risk of developing C. diff. So I think you can use all those things as educating points for your patients. So what's your responsibility as a healthcare provider? As a provider, when you're treating for respiratory illness or really anything, it's important to address the patient's concern. You want to be empathetic by showing personal interest. You want to explain to them what to expect for the course of symptoms. If you're not giving them an antibiotic and they feel like they might not get better without the antibiotic, you need to explain the course of symptoms so they know when to come back if things change or don't get better. And you want to use shared decision-making in treatment plan explanation, and then explain symptomatic management. So when we just talked about what is symptomatic or supportive care, if they might not know what that term means, so you just really need to explain those things to your patient. It is important to note, however, that prescribing antibiotics is up to the discretion of the provider and their clinical judgment. And as providers, continued education and knowing your resources is vital to your success. So let's test our knowledge with the last few minutes that we have in Grand Rounds. So for the first case study, we have got a 60-year-old or 68-year-old man that comes into our office with complaints of nasal congestion and ear pain. He reports that he developed nasal congestion 4 days ago, then has fever or cough. He has nasal discharge that is green, and he now has pain in his right ear. His vital signs are normal. On exam, his right eardrum is intact and he has clear fluid behind it. He has sinus tenderness and yellow-green mucus from his nose. So, do we want to perform any tests? No. We could diagnose him with a viral URI. You could test for COVID, flu, or RSV, but I don't think that would change our plan of care at this time. He has no evidence of an ear infection, and his symptoms are generally mild, and he has no fever. So will we prescribe an antibiotic for him? We won't. We would just send him home with supportive care and education and let him know to return if his symptoms extend beyond 10 days, or if he develops a fever that does not respond to antibiotics, or if he develops shortness of breath. So case study number 2, a 12-week-old girl is brought to the ED with concerns of a cough. Mom reports that the baby was full term and has been healthy. She developed a cough several days ago, and her cough has worsened so that she coughs until she vomits. It has become difficult for her to eat due to the cough, and mom is worried that she is becoming dehydrated. Mom reports that no fevers and states that the baby has had a mild, clear, runny nose, but no other symptoms. Her vitals are within normal limits, including her SATs, but on exam, clear rhinorrhea is noted. Breath sounds are clear. However, you witness a coughing fit that lasts for 1 minute, during which the baby gags and has some blueness around her mouth. So do we want to perform any tests in her? Well, more than likely, she's 12 weeks old, so she will definitely need some testing. She'll get a viral respiratory panel, which includes pertussis, but we do not need a chest x-ray at this time because her breath sounds are clear, and she does not have a fever. So her most likely diagnosis would be a pertussis or viral URI, and we would depend on the respiratory pathogen panel to tell us that. So will we prescribe for this? If she has pertussis, absolutely. And due to her age, she might get started on empiric antibiotics if she looked worse. But she probably will be admitted for observation due to those episodes of blueness around her mouth when she has her coughing fits. So case study number 3, a 40-year-old woman presents to the ED with complaints of shortness of breath. She states that she began to have a cold 8 days ago. Her symptoms were initially mild and consisted of nasal congestion, rhinorrhea, and a mild cough. She has also been using over-the-counter medications for symptom relief. And 2 days ago, she began to feel shorter breath with activity and has developed a cough with productive yellow-brown sputum. And today, she feels shorter breath just sitting down. And she has a fever of 101.5. Her respiratory rate is 24 and her heart rate is 108. Her blood pressure is within normal limits. Her oxygen saturations are 96% on room air. And on exam, she has crackles throughout the right lobe with decreased breath sounds in the right lower lobe. So do you want to perform any tests? Of course, we want to perform a chest x-ray because we suspect pneumonia. So on the differential list, she would potentially have community-acquired pneumonia. Her symptoms and physical exam are concerning for a potential bacterial source. And so because of this, we would go ahead and start on empiric antibiotics and supportive care. And we would potentially admit to the hospital depending on her work of breathing. She is tachypneic, she is tachycardic. So we might want to watch her a little more closely until we can get the antibiotics going and determine if we can de-escalate therapy or not. And I think we have time for just one more. So a 21-year-old man presents to the ER with complaints of a severe sore throat. He states that he woke up overnight with a terrible sore throat and a fever of 102.9. He denies cough or nasal congestion. He refuses to lie down for exam because it is easier to breathe sitting up. Vital signs show elevated temperature and heart rate, slightly low blood pressure. And on exam, the patient is drooling, says it hurts to swallow, has swollen lymph nodes in his neck, and clear breath sounds, but with mild stridor. So do we want to perform tests? What do we think this is? It sounds like epiglottitis to me. So we could perform imaging, but we need to make sure that the airway is stable first. And so because we suspect epiglottitis, would we want to prescribe? Absolutely. We would prescribe for epiglottitis, put him on antibiotics, and he would have a stat admission. All right. And so that concludes my grand round session for today. I'll open it up for questions. All right.
All right. If we don't have any questions there. So Kirsten, thank you so much. And next week, we're going to have Dr. Jenkins talking about microbiology. Thank you and have a good day.